acute kidney. Today, I'm going to present drug modifications in acute kidney injury. Now, what is the importance of drug dose modifications in AKI? Now, we see two clinical scenarios, okay, in our daily practice. Sometimes, okay, we are not aware of the setting of acute kidney injury, which results in unrestrained drug dosing, result in drug toxicity. On the other hand, many clinicians are afraid to administer drugs because of the fear of drug toxicity. This results in underdosing with subtherapeutic drug levels, resulting in drug failure. The hindrances in optimizing drug doses in a setting of AKI include limited facility of therapeutic drug level monitoring. Number two, limited access to the pediatric databases. And number three, undermining of the non-renal clearances of drugs. If we optimize drug dose during the setting of AKI, we can maximize the efficacy of the drugs, and we can minimize toxicity and minimize the development of antibiotic resistance. Today, the subheadings that I'm going to talk about is changing pharmacokinetics in kidney function. Number two, assessment of kidney function in the setting of acute kidney injury. Pharmacokinetic targets of various antibiotics to optimize bacterial killing. Drugs and membrane properties that affect dialysability. And finally, the principles of drug dosing in renal replacement therapy. The pharmacokinetic properties are altered in renal dysfunction. Number one, bioavailability. The uremia in the setting of acute kidney injury alters enteral absorption of the drugs. It also induces vomiting or gastroparesis, leading to decreased drug absorption. Also, the proton pump inhibitors or H2 blockers, which are used in critically ill children in the ICU, may change the ionization status and may alter drug diffusion through the GI wall. So the oral bioavailability is hampered. So in critical children, IV administration of drugs is encouraged to ensure 100% bioavailability. Now moving on to the volume of distribution, it is the apparent volume or the theoretical volume into which a drug disperses in order to produce the observed plasma concentration. Therefore, Vd, which is the volume of distribution, is equal to dose divided by the plasma concentration. Now, the volume of distribution is higher in children as compared to adults because the total body water content in children or the pediatric population is comparatively or proportionately higher compared to the adults. It depends upon the body composition. Like if the fat content of the body is higher, the lipophilic drugs will be more distributed into the fat compartment, thus giving rise to a high volume of distribution. The total body water in children with who are critically ill and admitted in the ICU, they are sometimes in a positive balance of over 4 to 5 liters. So the volume of distribution of the drug increases in such situations. The protein binding capacity. Drugs which have a high protein binding capacity have a high volume of distribution, and drug properties like the hydrophilic versus lipophilic drugs. Like hydrophilic drugs will be more restricted to the intravascular compartment and does have a low volume of distribution, whereas lipophilic drugs are distributed into the fat spaces and have a higher volume of distribution. Hypoalbuminemia is another factor because it increases the concentration of free drug in the plasma. Thus, the volume of distribution of the drug decreases. Now, this is the most important slide of the presentation. In this, we discuss the drug dosing strategy or the approach to drug modification in acute kidney injury. Now, first of all, we need to identify the cause of renal dysfunction, whether it is acute or chronic, and what are the factors which has caused the acute kidney injury. It could be sepsis, drug-induced, or immune-mediated. If there is an offending agent like a drug, we should remove that drug. Number two, assess the overall condition of the patient. If the patient is critically ill, having multi-organ dysfunction, admitted in the ICU, or is it a stable patient who is just having maybe fever with increase in creatinine because of some septic focus? Why this is important? Because in critically ill children with multi-organ dysfunction, they have a greater positive balance of fluid. Thus, the volume of distribution of the drug is going to increase. Number three, we have to estimate the creatinine clearance or the glomerular filtration rate, which tells us about the working status of the kidney. Number four, decide if the child needs renal replacement therapy. This will depend upon the clinical and the biochemical the parameters, which will help us to determine whether the child needs a renal replacement therapy. Number 5, adjust drug dose or dosing interval based on the action that best promotes efficacy. Now, if the child is needing dialysis, then we need to analyze the effects of dialysis on the drug dose. And if needed, supplemental doses in case of intermittent hemodialysis might have to be administered. Whenever possible, we should consider drug-specific safety monitoring, like drug level monitoring. And finally, consider interactions with other currently prescribed drugs. Now, with this approach in mind, we are going to move forward into the discussion. Now, first of all, the assessment of kidney function in patients with acute kidney injury. This is the most challenging task. Why? Because any endogenous filtration marker needs to be measured in a steady state. Say, for example, creatinine. It has to be measured in a steady state before it can provide a reliable estimation of GFR. We know that in acute kidney injury, there is a fluctuating kidney function. The volume status is dynamic. It is not constant. And there is a fluctuating metabolic activity. So estimation of kidney function in AKI may be done via a 4 hours estimation of urinary creatinine clearance with incorporation of the mean of the beginning and the end serum creatinine values. Usually children who are admitted in the ICU who are very critically ill, they will usually have a very tight monitoring of the urine output. So they were usually catheterized. So it is not very difficult for us to obtain a 4 hours urine sample. So from that urine sample, we can get a creatinine clearance in ml per minute, which is equal to the creatinine concentration in urine in milligram per deciliter multiplied by the volume of urine in ml divided by the plasma concentration of creatinine in milligram per deciliter multiplied by 4 hours and 60 minutes. This will give us the creatinine clearance. But in case the child is anuric, we'll have to resort to the Schwartz formula, which says that eGFR is equal to 0.413 into height in centimeters divided by the serum creatinine. Now, after we have assessed the status, the functioning status of the kidney, and say, for example, that the child is in sepsis, so we'll have to prescribe an antibiotic. Now, when we prescribe an antibiotic, we'll have to understand the killing characteristic of the different antibacterial and the various pharmacokinetic targets that we have to achieve to optimize bacterial killing. Now, the mechanism of action of the different antibiotics can be of 3 types. Number 1 is the time-dependent killing. It means that the concentration of the drug in the plasma should be above the threshold level for a certain or a stipulated period of time. It can be 40% out of 24 hours up to even 90 or 100% out of the 24 hours period. Now that depends upon which organism we are trying to chase or which drug we are using. Such examples of time-dependent killing would be the beta-lactam antibiotics like piperacillin, tazobactam. We have the entire cephalosporin range, and we have the carbapenems like imipenem and meropenem. They are the beta-lactam antibiotics. Now, why it is important to know this? Because this is they exhibit time-dependent killing. So we'll have to modify the drug dosing in such a way that after we give the first loading dose, then we have to give subsidized dose maybe at regular intervals or maybe slightly increased interval. So the priority will be maintaining the concentration of the drug. That is the motive for time-dependent killing. Number 2, concentration-dependent killing. This is exhibited by antibiotics like aminoglycosides, like amikacin and gentamicin. Now, for these drugs to act, a peak concentration of the drug in the plasma has to be reached to achieve maximum bactericidal activity, as is shown in the graph. And so what happens, why do we should know this? Because with this mechanism, when this pharmacokinetic target we are trying to chase and we target a drug dose modification, so we have to get this plasma peaks maybe at greater intervals. So this is the modification that we have to make in patients with acute kidney injury. And there are some drugs which will exhibit both concentration and time-dependent killing. Now, this is an example, as is seen from the graph, that a dose of aminoglycoside was administered just 30 minutes, just 30 minutes before the session of hemodialysis, and it was given as a 30 minutes infusion. So there was a peak in the concentration of gentamicin in the plasma, And after that, there was a fall post-dialysis. So maximum bactericidal activity can be achieved with this modification. This demonstrates that a large dose of gentamicin administered immediately pre-dialysis to achieve maximum concentration of drug-dependent killing and post-antibiotic effect. Rapid clearance achieved by dialysis ensures minimum toxic effects. As we clearly see from the graph that the same dose given post-dialysis, the blue line over there, it will have more toxic effects. Now, this is a chart showing the killing characteristics of the different antibacterials and pharmacokinetic targets associated with optimal bacterial killing. Like the beta-lactam antibiotics, I've told they have time-dependent killing. So 40% to 100% okay, of the total time duration, the drug concentration has to be above a specific level. And the MIC can be from the range of 1 to 5. Aminoglycosides, they exhibit concentration-dependent killing with a Cmax to MIC ratio of 8 is to 10. Fluoroquinolones, they exhibit both concentration and time-dependent killing. Vancomycin and linezolid, they also exhibit concentration-dependent killing, but it is expressed as area under the curve in 24 is to MIC ratio. And macrolides, they also exhibit concentration-dependent killing. Now, after understanding what drugs or antimicrobials we have to use and how we are supposed to dose them, whether we are supposed to reduce the dose frequency, reduce the dosage or increase the dose intervals, then we also need to know what are the drug properties that affect dialysability. So number one, the molecular weight and the size. Like it means that what is the flux or the pore size of the dialyzer that we are using. If we are using low flux dialyzers, they do not allow a wide clearance of the drugs, maybe maximum up to 1,000 dantals. But if you are using high flux dialyzers, they can help dialyze up to 15 to 20,000 daltons molecule size by the filters. The protein binding capacity. Now, drugs which are greater than 80% protein bound are poorly dialysable. Uh, then the electrostatic charge, the cationic drugs, which are retained more in the circulation because they are bound to the anionic proteins, and the anionic drugs are lost more easily during dialysis. Intercompartmental equilibrium and the volume of distribution. So the drugs with a low volume of distribution, like the beta-lactam antibiotics, aminoglycoside, and glycopeptides, that effectively remove, whereas drugs with a higher volume of distribution, like the macrolides, tetracyclines, fluoroquinolones, and linezolid, are not effectively removed. In general, we see that drugs with a volume of distribution, which are less than 0.7 liters per kg, are well dialyzed, and those with greater than 1.5 to 2 liters have a low and variable dialysability. Like we have understood the drug characters related that affect dialysability, also the dialysis related variables that affect dialysability, like the blood flow rate, the dialysis flow rate, the ultrafiltration rate, they also affect the dialysability. And the membrane properties, like the pore size, means the flux of the filter, high flux or low flux, dialyzer surface membrane. So these are the important properties. Now, drug clearance during dialysis can occur both via convection and diffusion. Now, convection is important for removal of the middle and the last size molecules. It is dependent on the surface area of the dialyzer, the membrane pore size, which means whether we are using a high flux or a low flux dialyzer, and the hydraulic pressure gradient electrolysis membrane. Diffusion, on the other hand, depends upon a favorable concentration gradient, which is facilitated by the countercurrent flow of blood and the dialysate fluid increases as the molecular weight of the drug decreases. Now, after we have understood these principles, now how do we go about drug dosing during intermittent hemodialysis? Now, we see that many of the critically ill children, okay, who are admitted in the ICU, they maybe in a positive fluid balance. Why? Because they might have required initial boluses during resuscitation. There is increased capillary leak. They may have extravasation into the third spaces, ascites, pleural effusion. So the volume of distribution, okay, of the drugs increase. So Kidiko states that as the volume of distribution of many drugs, especially the hydrophilic antibiotics, are significantly increased in acute kidney injury, the administration of aggressive loading doses are recommended 25 to 50% greater than normal. Why? Because a rapid onset of effect is required. Because children who are into sepsis, with multi-organ dysfunction, with every hour, the mortality is increasing. So we require a rapid onset of action. So higher loading doses are warranted. Now, this is a graph or a picture which is showing us that when we are using and loading and maintenance dose together, we can clearly see that the therapeutic drug levels are achieved much faster. So we see that when the T half is prolonged due to decreased endogenous clearance, as it happens in acute kidney injury, the time to achieve a steady state plasma concentration is increased proportionately. A loading dose decreases the time to achieve therapeutic plasma concentration. Now, maintenance dose. Now, this depends upon the clearance of the drug. The maintenance dose of many drugs, especially antimicrobials, should be initiated at near normal dosing regimes. Now, drug doses due around the time of dialysis session are usually given post-dialysis. Now, this statement is very important because many times we see that the patient is being dialyzed and the drugs are going at their own frequency and the dialysis on its own frequency. Now, that should not happen because that will that will hamper the concentration of the drug in the blood heavily, which will affect the overall outcome of the patient. So we should be very careful in timing the drug doses as per the dialysis sessions. Now, let us try to understand drug dosing in children with AKI with an example. So, we have over here a 3 years old male child who is a known case of bilateral grade 3 vesicoureteric reflux on uroprophylaxis and is admitted with high grade fever for the last 5 days. So, the blood picture shows leukocytosis with high CRP, and the urine culture reveals growth of pseudomonas, which is sensitive to ceftazidime. Now, USG shows bilateral edematous kidney suggestive of pyelonephritis, and the blood urea is 70, and the 4 hours urinary clearance is 45 ml per minute. Now, we know that the regular dose of ceftazidime is around 50 milligram per kg every 8 hours. Now, let us have a look at the renal dose, the drug dose adjustment in renal impairment for ceftazidime. So, if the creatinine clearance is in between 30 to 50 ml, so we will give uh, one normal loading dose initially, 50 milligram per kg, followed by maintenance of 25 milligram per kg, 12 hourly. So this loading dose is very important. Why? Because if we don't give this, the therapeutic drug levels will be reached very late, and maybe the child can deteriorate. And then, keeping in mind that ceftazidime is a beta-lactam antibiotic, which shows time-dependent killing, so subsidized doses at maybe greater intervals, like from 8 hours, we're giving at 12 hours. So this will help to maintain a steady plasma concentration of the drug, which will ensure a maximum bactericidal activity. Now, similar example for teicoplanin. So if a child is having a GFR of less than 40, for the first 3 days, we will give him a normal loading dose of maybe 10 mg per kg every 24 hourly. And then after the third day, we make the drug once in 72 hours. So this again ensures a steady drug levels in the blood. Now, when we are doing intermittent hemodialysis, we often forget to this concept of supplementary dosing. Now, if the drug is significantly removed post-dialysis, a supplemental dose should be given. Now, the formula for supplemental dose is the concentration desirable minus concentration obtained into the volume distribution. But drug level monitoring is very difficult in most of the circumstances. The drugs requiring supplemental doses, a few examples are given over here, like meropenem, which is 50 to 70% dialyzed, piperacillin tazobactam, which is 30 to 50% dialyzed, valproic acid. Now, this is an example I've given. Say, for example, some person is on piperacillin tazobactam. So after hemodialysis, 150% supplemental dose, 50% of the dose should be given IV post-dialysis on dialysis days, because hemodialysis removes 30 to 50% of the piperacillin in 4 hours. Now, this is a very important concept, therapeutic drug monitoring. Now, this is a superior method of dose adjustment in the setting of altered physiology, and it should be done whenever possible. It overcomes individual variations in pharmacokinetics and guides the delivery of individualized drug therapy. It is important for drugs with a narrow therapeutic index administered in the setting of acute kidney injury. For example, aminoglycosides, vancomycin, and digoxin. The only disadvantage is that the levels should be obtained at appropriate times, and the turnaround time, okay, is of the reports usually not in the frame which is clinically useful to the patient. In most of the settings in India, it will take maybe at least 2 days. Now, this is another example. See, if, for example, we are going vancomycin, giving vancomycin to a patient who has a creatinine clearance of less than 50. So we give a dose of 10 milligram per kg. So depending upon the creatinine clearance, maybe after 12 to 24 hours, we'll have to go for a drug level. And if the serum trough levels are in between 5 to 10 milligram per liter, then we can go for the next dose. Now, assessment of the impact of hemodialysis, the most common method is the clearance of the drug. Now, this is based on the difference of concentration of the drug in the blood going into the dialyzer and the blood leaving the dialyzer. And the renal recovery approach, it is the benchmark for calculating dialyzer clearance. And it is based on the amount of drug recovered unchanged in dialysate. But it's very difficult to measure the drug levels actually. Uh, so moving on to the principles of antibiotic prescription during continuous renal replacement therapy. So most of the patients who are on continuous renal replacement therapy, they're admitted in the ICU. They're usually very sick children with a large positive balance of maybe 5 or 6 liters, and they are oligoanuric, and they're very sick children on inotropes who are hemodynamically unstable. So the volume of distribution is high in such children, and the volume distribution only determines the initial loading dose in children with CRRT. Subsequent doses are determined by the total drug clearance. Now, the total drug clearance is calculated by adding the CRRT clearance plus the non-CRRT clearance, which may be mainly the residual renal, the hepatic clearance, and the transintestinal clearance. Now, one very important thing is that no, this concept of supplementary dosing is not there in CRRT like we have in infant hemodialysis, and the antibacterial doses will need to be adjusted whenever CRRT doses are altered. So to understand the clearance of drugs in CRRT, we have to understand something which is called as the sieving coefficient. So the sieving coefficient is the concentration of drug in the ultrafiltrate or the dialysate relative to the plasma is expressed as sieving coefficient or the saturation coefficient SD. So SC is equal to the concentration of drug in the ultrafiltrate divided by the plasma concentration of the drug. So there are various modes of CRRT, like we have the CVVH, in which the key parameter influencing drug removal is convection. We have CVVHD, in which the key parameter influencing drug removal is diffusion, and CVVHD, in which both convection and diffusion, they take part in drug removal. So depending upon the mode which we are using, we have these clearance formulas. Like say, for example, clearance in CVVH will be equal to the ultrafiltrate rate multiplied by the sieving coefficient. So similarly, we have for the other modes also. So this is an algorithm which tells us about calculation of antibacterial drug doses based on first principle. So as I've told that the children who are receiving CRRT, they will have a high volume of distribution. And so the loading dose will be equal to the desired concentration into the volume of distribution. Say, for example, if you're using a beta-lactam antibiotic, so the MIC that we usually target is around 5. So 5 multiplied by the volume of distribution. The volume of distribution can be obtained from these charts. So that can give us the idea of the loading dose. And the maintenance dose, it is based on the clearance, the calculated CRRT clearance and the non-CRRT clearance. From the CRRT clearance, we can get it from these formulas, and in the non-CRRT clearance, again, we can get these from these charts. So after we calculate the total clearance, how we are going to give the maintenance dose depends upon what pharmacokinetic target uh, uh, we are trying to achieve. Say, for example, we are using a beta-lactam antibiotic like meropenem, so which has a time-dependent killing. So for that, we can calculate the elimination rate, and we can give a continuous infusion of the drug. Say, for example, meropenem, a continuous infusion in critically ill patients, changed every 4 hourly. So we can do that. And for drugs who have a concentration dependent killing, so we can calculate the time interval after which the second loading dose has to be given using this algorithm. So these are the pharmacokinetic data for antibacterials. used in ICU. And from this, we can calculate the CRRT loading and the maintenance doses. Now, coming to drug dose modifications or considerations for patients on peritoneal dialysis. Peritoneal dialysis does not enhance drug removal to the degree that will require a dosage regimen modification. Most typical peritoneal prescriptions are designed to achieve a urea clearance of around 10 ml per minute. As most drugs are larger than urea, drug clearances are in the range of 5 to 7 0.5 ml per minute. Thus, drug dosing modifications are those with creatinine clearance or eGFR less than 15 ml per minute per 1.73 meter squares. So finally, we come to the last slide of the presentation. Our take-home messages would be overdosing as well as underdosing of drugs can be detrimental to patient outcome. Appropriate loading doses are necessary to achieve target serum drug levels to obtain maximum effectiveness. Supplemental doses for intermittent hemodialysis are necessary to maintain therapeutic drug levels. Periodic assessment of renal functions are necessary for drug dose titration. Therapeutic drug level monitoring should be done whenever possible, and peritoneal dialysis requires no major drug dose modifications. Thank you.
Thank you, Partha. If anyone has any queries or they have any comments on the presentation, please. After that, and I would also like fellows to kindly volunteer so that I can make the breakout rooms for the discussion of the MCQs.
Though Jyoti, I think there are not many fellows today who are attending. I can only see, I can see Monica and Madhura, Neha.
So ma'am, then we'll just ask them to answer in the chat box then.
Yes, because I can only see 3 people.
Okay.
Ma'am, I'll stop sharing.
Yeah, sure.
Okay.
So ma'am, should I go ahead with the asking the MCQs?
I think so. Yeah, go ahead. And then if we have comments from anybody, we can they can ask or them later. Yeah.
Sure. So coming to MCQs discussion, I would like the fellows in the group to please answer the options in the chat box. Which one of the following is true regarding the drug pharmacokinetics in patients with AKI? Neonates have lower volume of distribution of hydrophilic drugs as compared to older children. Children with AKI can have reduced clearance of drugs eliminated by liver. Children with AKI have normal bioavailability of orally administered drugs, and protein binding of drugs is preserved in AKI, preventing increased levels of free form of drug in the plasma. Ma'am, do we have the answers or should I go ahead with the...
No, you are getting answers. So Monica, Partha, you need the answer because you are presenting. So Monica's, so there's answered B, Madhura B, Nikita's also answering. Good. So I thought she's finished her exam and she may not be wanting to answer. So she's answered B. And there's some more people who should be answering, I think. Where is Neha? Neha, I'm not going ahead till you put something down. Come on. You have to answer. Whoever I can see in the fellows have to answer. Otherwise, we're not going to go ahead. Okay, so everybody, yeah, okay. So everybody's answered B.
Okay, so I think Partha has done a good job. So the neonates do have a higher volume of distribution because their total body water is more as compared to the older children. So the volume of distribution is higher in them. So that sentence is incorrect. And children with AKI, as Partha has correctly covered, that can have decreased bioavailability of orally administered because of various reasons, because of the gut edema or they have other problems like vomiting and gastroparesis in uremic condition. And protein binding of drugs also gets affected in cases of acute kidney injury. Either the quality of protein binding is affected or the uremic toxins in itself might compete with the protein binding, thereby leading to increased free form of some of the drugs. So we need to be really careful about these drugs while we are prescribing in AKI to prevent their increased concentration in free form, which can otherwise create toxicity. So the answer is B. Coming to next MCQ, which one of the following is true regarding drug removal by peritoneal dialysis? Clearance of higher molecular weight drugs may be increased by PD because of secretion into peritoneal lymphatic fluid. PD is more efficient in removal of drug than HD because of its continuous nature. Peritonitis-induced inflammation leads to decreased absorption of intraperitoneal antibiotics, and drug removal by PD is most effective for middle molecular weight drugs. Ma'am, do we have the answers?
Are answering, just hold on.
Okay, ma'am.
This topic is not so easy, so you can't expect answers stat.
Yes, ma'am.
So far we have C as the answer by 1, 2, 3 people.
Okay.
2 more should answer unless they've gone off on call for something. I think you just give the correct answer.
Okay, so the correct answer is A. So first I'll discuss the rest of the answer. So PD is less efficient, even though overall, if we see the PD over a period of time can cumulatively help in removal of the drug, but efficiency wise, it is less efficient as compared to hemodialysis in drug removal. So that's false. And peritonitis induced inflammation, in fact, leads to increased absorption of intraperitoneal antibiotics. And drug removal by PD is more effective for small molecular weight drugs. The sentence A, though the clearance of the higher molecular weight drugs is not more with PD, but there may be some secretion into the peritoneal lymphatic fluid in cases of peritoneal dialysis. So in this case, we might have to adjust, not exactly lower the drugs doses while we are using them if the child is on peritoneal dialysis. So going on to third MCQ, which one of the following is true regarding drug dosing in CRRT? The molecular weight of the drug is the most important factor determining removal by CRRT. Drug removal efficiency for drugs between 2000 and 15,000 Daltons is more with hemodiafiltration than hemofiltration. Pre-filter replacement fluid increases the clearance of drugs with small molecular weight, and drug removal is considered clinically significant when more than 25% of the administered drug is removed by dialysis.
Okay, so the answers are D, A, and D. Yeah, so basically some people have answered D and A.
Okay, so the answer is D. So going option wise, so in CRRT, the most important factor determining removal is the volume of distribution. Because if the volume of distribution is high, the less of the drug will be present in the intravascular compartment and the less of the drug will be available for the removal in the CRRT filter. So molecular weight of drug is not the most important factor. Then secondly, the efficiency of drug removal of this molecular weight size drugs is more with hemofiltration as compared to hemodialysis filtration. For small drugs, small molecular weight drugs, if we use replacement fluid pre-filter, it will dilute the concentration of this drug when it is passing through the dialysis, when it is passing through the filter, thereby decreasing the clearance. And fourth holds true for any form of dialysis modality, that if the drug removal is more than 25% of the administered drug, then only it is considered as significant. So D is the correct option. Going to the last MCQ, which one of the following regarding various drug statement is true? Thiazide diuretics in large doses can produce diuresis in patients who have GFR less than 30. The concentration of active free drug phenytoin is lower in patients with uremia. Amlodipine dose adjustment is needed when eGFR drops to less than 10 ml, and dose of losartan remains unchanged in any degree of renal failure.
So the answers that have come are D, A, and B. And yeah, that's it.
Okay.
2 people have answered B, D, and A. 1 person has answered A.
Okay. So as we know, in low, when the eGFR really falls below 30, thiazide diuretics should not be used. In fact, it can be harmful. So in this cases, loop diuretics work much better than thiazide diuretics. And as we were discussing, the phenytoin drug is highly protein bound. And in case of uremia, the uremic toxins will displace phenytoin from the protein and thereby lead to increased free fraction of phenytoin in the blood. Thereby, it can lead to chances of increased toxicity if we keep the dose of the drug in the same and if you fail to alter it. And amlodipine dose adjustment is not required in any degree of renal failure. So C is also wrong. The correct answer is dose of losartan need not be changed in any degree of renal failure. But of course, if you have hyperkalemia, then you would like to hold losartan for preventing the exacerbation of that hyperkalemia. Otherwise, dose adjustment is not needed. So that finishes with the MCQs. So, ma'am, should I just go ahead with the summarizing presentation, or if anyone has any comments or?
Dr. Umali, ma'am, do you want to say something now?
I think let her summarize, then I'd like to say a few things at the end of the summarization.
So, Jyoti, go ahead then.
Yes, ma'am. So just reiterating the steps which Dr. Partha has already presented, that whenever a child with AKI comes to you, first evaluate the medications which the child is already on so that it does not exacerbate the injury. So you would like to stop the nephrotoxic medications and drugs like ACE inhibitors and ARBs. In cases of, and if the AKI is oliguric, you will like to stop the drugs to prevent the chances of hyperkalemia. Then adjust the dose of any chronic drug if the child is receiving according to the GFR. Drugs like immunosuppression if the child is receiving MMF, or any anticonvulsant for if the child is a case of seizure disorder. Then you would estimate eGFR, and depending upon that, you will adjust the dose based on the GFR, based on the drug characteristic and any mode of dialysis which you are going to use. So this is just reiterating the steps which already Dr. Partha has covered. So this one thing I would like to discuss is the kinetic eGFR formula. So as we all know, the GFR formula, which we all use, the Schwartz formula, it has been based for calculation of eGFR in children with chronic kidney disease. So there's a need of a kinetic GFR because AKI is not a steady state. So the creatinine keeps on fluctuating, and it's important to know the actual GFR, which is, as we all know, that the serum creatinine lagged behind the actual renal injury. That is also the reason which we are in search of novel biomarkers for detection of AKI at the earliest and to take action at earliest and to prevent further injury. Similarly, this kinetic eGFR formula has been devised, which takes into account initial serum creatinine, the volume of distribution, as we know that it gets altered in cases of AKI, the creatinine production rate, and the differences between two creatinine values, and time between two serial creatinine measurements. So this is the formula which has been devised. It takes into account the steady state plasma creatinine, the creatinine clearance calculated from the steady state, the mean plasma creatinine, which we can calculate from mean of any two available serum creatinine, and 1 minus 24 into delta plasma creatinine, that is change in the plasma creatinine which has happened over a period of time, that is time in hours, and maximum change in plasma creatinine per day. So this maximum change in plasma creatinine per day for any person depends upon the generation of the creatinine and the volume of distribution, which can be again calculated by this formula. For simplification, the kinetic GFR can be calculated as baseline serum creatinine into eGFR calculated from this baseline serum creatinine. And if we don't have a baseline serum creatinine for any patient, we can back calculate it divided by the mean serum creatinine, and the rest of the formula remains the same. For easy purpose, the maximum change in serum creatinine is the creatinine if the child or if the patient has been anuric, which for simplicity purposes is considered as 1.5 to 2 milligram per day. And so the kinetic eGFR can be calculated. So I just thought of including this hypothetical case, which Dr. Sheldon Chen in his paper had shown for showing the importance of this kinetic eGFR formula. So this was a hypothetical case where a 50 kg old gentleman had an intraoperative hypotension, suffered acute tubular necrosis, and post-operative also developed sepsis. So as we can see in the table on the right side, that the consequent creatinine done on different time periods in the post-operative period showed gradual, slowly increase in the serum creatinine. So if you look at the graph on the left hand, so the x-axis is the day on which the serum creatinine and the creatinine clearance has been calculated by the normal MDRD formula, which is used in adults, and the kinetic eGFR formula. On the left y-axis is the serum creatinine, and of the right y-axis is the eGFR. So as we can see on the post-operative day, when he suffered a hypotension and had a renal injury, the serum creatinine kept on rising not only because of the intraoperative hypotension, but also because of the post-operative developed sepsis. So here when we see as the creatinine is increasing, the creatinine clearance calculated this in the green boxes is lagging behind as compared to the kinetic eGFR formula. If we would have calculated it on the postoperative day 1, we can see that it has fallen quite a lot as compared to the creatinine clearance equation. So here we can detect AKI at the earliest, and let's say if we want to use antibiotics and have a quick effect, we can dose it accordingly. So this was one of the, and we can see the creatinine clearance reached the kinetic eGFR much later, that is on post-operative day 6. While if we would calculate kinetic eGFR, we could have detected the severe AKI on the day 1 itself. Similarly, for the renal recovery, let's say this was the same patient who just had a intra-op hypotension, suffered acute tubular necrosis, and post-operatively was otherwise stable, didn't have any nephrotoxic result, insult, or any other process which would have really worsened the creatinine. So here we can see on the post-operative day 1, though the kinetic eGFR had fallen, but if we don't rely on the rising creatinine, which again lags behind even for the renal recovery, and if we concentrate on the kinetic eGFR formula, it shows that it is building up and that the kidneys are recovering, thereby negating the need of dialysis if it would have been contemplated at this point of time, that is post-operative day 1. So this kinetic EGFR formula helps in detecting the renal recovery as well. Similarly, if we consider the case 1, where on post-operative day 6 also, since the GFR was very low at 10 and CVVH was initiated, so the creatinine keeps coming down because of the initiation of the CRRT. And from day 7, we can see that the kinetic EGFR is maintaining at 25 ml per minute, and slowly the GFR is also increasing. So in this case, this constant kinetic EGFR of 25 ml per minute tells us it attests to the continuous and steady nature of CVVH therapy. So by the end of 2 weeks, if we say that the creatinine clearance or the kinetic EGFR is staying at 25 ml per minute, so this is probably because of the 15 ml per minute clearance provided by the CRRT and the 10 ml per minute of the which the kidneys is mustering to provide. So this just attests to the continuous and steady nature of the CRRT. The kinetic EGFR helps us in that, proving that thing. So there have been evaluation of medication dosing in acute kidney injury evaluating using this kinetic EGFR formula, where they have found that use of this formula impacted drug dosing in a quarter of all subjects during the first week of admission, and almost 8 to 10% of study days among the AKI patients were impacted if we use the kinetic GFR formula instead of the normal creatinine clearance equation. So one study was done in Pondicherry where they tried to see the agreement between the KEGFR model and KDIGO criteria, and they found that there was a good correlation between the AKI severity in critically ill children as if we take the KDIGO criteria as compared to KEGFR model. So just summarizing in short, the pharmacokinetic changes which occurs in acute kidney injury is there is a larger volume of distribution because of increased extracellular fluid or because of the use of fluid used for resuscitation. There can be prolonged drug half-life as the drug metabolism is also reduced at other organs like liver, and there is reduced renal clearance as well. And as we discussed, because of the hypoalbuminemia and uremic toxins competing with the protein binding, there can be increased free fraction of the drug. So we need to keep in mind all these pharmacokinetic principles while dosing in patients with acute kidney injury. So drugs with high volume of distribution have poor removal by any dialysis modality. They can have rebound effect post-HG, has been studied best in gentamicin and vancomycin. And so it's important that we use the loading dose, especially for antibiotics, to attain quick therapeutic levels. And drugs with increased protein binding, those who have protein binding more than 80%, acts as substantial barrier to removal by any form of dialysis, either diffusion or convection. And uremic toxins can displace the drug, resulting in increased free fraction of the drug. Small molecular weight drug can be easily removed by conventional HD, while high flux dialyzers can remove drugs up to molecular weight of 40,000 Daltons. And the type of modality, the ultrafiltration rate, the dialysis flow rate, the type of the filter, high flux, low flux, and the patient's residual renal function, all has to be taken into account while drug dosing in these children. And drug dosing in PD, the adjustment should be as per a child with GFR less than 15 ml per minute. So this is short in summarizing the classes of antibiotics and their potential dosing strategies, which can be used depending upon the time profile which they have. So if the antibiotic is concentration dependent, loading dose is advisable with extended dosing interval for aminoglycosides. And as Dr. Partha has mentioned, the large dose installation of pre-dialysis administration of aminoglycosides in patients with intermittent hemodialysis or prolonged intermittent renal replacement therapy can be helpful to achieve therapeutic targets sooner. And for antibiotics which are time dependent, more frequent administration of smaller doses is advisable, and supplemental dosing should be given during a prolonged intermittent renal replacement and in case of intermittent hemodialysis after the session of the hemodialysis. And in cases of CRRT, as it's a continuous process, a continuous or prolonged infusion should be used. Thank you.
Thank you very much, Jyoti. There's a question from Dr. Thirgaonkar in the chat. He wants to know whether Chen's formula can be used for children.
So, ma'am, the study which I had shown of Pondicherry, they have used the same GFR formula for children from 1 year to 17 years. And around 60 patients they had enrolled. but their target was, their objective was to assess the whether how well it correlated with the KDIGO criteria of severity of AKI. They didn't check it in terms of drug dosing in pediatric population.
Thanks. Ma'am, your comments?
Yeah. I think first I'll congratulate both Partha and Jyoti for the excellent presentation of a difficult topic. It's maybe easy to understand when you read it because you're reading it thoroughly, but it's not always easy to communicate it to people who have not read it so lucidly and in such a short time. So Partha, I must congratulate you for your excellent presentation, and
Thank you so
to
much,
Jyoti
madam.
for bringing out all the right ways and also addressing the kinetic EGFR. To the best of my knowledge and my reading, I don't think the kinetic EGFR has been validated in children, because validation will require use of a gold standard to compare it, which means you would need to do something in a sick child, which can be considered as a gold standard, which is not very easy to validate. So even in adults, it's a physiological concept which has been put into use, expanded, and now being used in centers, but it makes good sense because the assessment of the true GFR is a huge problem, especially when you have a critically ill child. uh, everything is works the other way around. Like if you look at your creatinine value is telling you what happened 3 days ago. It's not telling you what's happening now. Okay, it's like the star, the light you're seeing, that light emanated from that star some so many light years ago. So you think you're seeing the star now, but what you're seeing is the star which was there some millions of years ago. So that's what is happening when we choose creatinine as a marker to judge AKI in acute illness. Also, the creatinine gets diluted because the present way we treat critically ill children, although we become more restrictive, more moderate in fluid therapy, we still use a lot of fluids, and they also have capillary leak, etc. So the actual creatinine may be diluted by the amount of fluid we are giving and may be spuriously low. Third, if the child has been ill for some time because he became septic, he may have muscle wasted, and so his creatinine production is low. So again, a low spurious creatinine will be there, even though there is AKI. So when you use just a single creatinine marker, you may totally misestimate the actual GFR of the child. Second message, which was brought out very well, is that the eGFR we calculate by Schwartz formula was designed for chronic kidney disease when the creatinine is stable. So it is not for acute kidney injury at all. It has been used by default because we don't have anything else, or we as nephrologists have failed to understand the complexity of critical illness and AKI GFR. So you would need something better. And the easiest is what Partha has mentioned, do a 4 hours creatinine clearance, which is quite feasible in the ICU setting because blood collection is not an issue. There's a line there. And urine is always monitored by catheterization. So one could do a daily 4 hour creatinine clearance also to see the changing GFR. The kinetic GFR is a very good model, but I think for pediatrics, probably somebody would have to take up the study and do it and validate it, etc., before we use. But it probably would still be definitely be superior, even if it's little erroneous in children, compared to a plain simple EGFR that we tend to do. So I think the focus, this focus is important of true assessment of your glomerular filtration rate. The other important point brought out in this presentation and discussion is the very important point of a loading dose. We tend to forget that loading dose is very important in critical illness and in renal failure. as Partha rightly brought out, your T half is prolonged in renal failure because your clearances are poor. So the half-life of the drug is going to be more. So you will need 5 times your half-life to reach a steady state. So normally what you may have achieved in 48 hours, you may take 4 days to reach that steady state, by which time your child will not be responding and you will inadvertently change to another drug. It's not that it's not responding to the drug, but you're not using the right dose. So the right dose is always a loading dose to reach the therapeutic level, and subsequently and adjust your maintenance dose based on the degree of GFR and based on whether it's a concentration dependent drug or a time dependent drug. In ICU, time dependent drugs are, that is why, given as infusions, whether they're 3 hours, 4 hours, continuous, whatever, varies from drug to drug and unit to unit, because it gives you a steady time over the MIC at a good level. So your action is likely to be better than if you just give a bolus of meropenem. It stays high for 30 minutes and then starts coming below the MIC. So it's not long enough above the MIC to allow for bacterial killing. And most of these time-dependent drugs in the beta-lactam family, unlike aminoglycosides, do not have a post-antibiotic effect. That means if the drug is gone, level below MIC, the bacteria will grow again. Whereas gentamicin, even if it falls below MIC, will have an inhibitory effect on the growth of bacteria. So I think all these are important points which were brought out and to be kept in mind. I think a serious, what do you call it? Losing the right word, but I would say a gap in fellows training is that there is a variability in the exposure of pediatric nephrology fellows to critical care. I think that interface is very important, because when you pass, if you have not had critical care exposure, you cannot treat these children with sensibility. You would probably doing a disservice because you do not know how to treat critical care children. And critical care grows at a far more rapid rate than nephrology. So the practices, the changing concepts, everything is very rapid there. So I think it's very important that fellows rotate in ICU. Even if you finished your 1 year's post, do it as a your own interest, a rotation of 3 to 6 months in critical care, so that you have a ground reality of how you do all these things. So I think it was a very excellent presentation and discussion today. And so I leave it open for anybody else for questions and comments.
Thank you, ma'am.
So if there are no more questions, I would also really like to congratulate Jyoti and both Parth. Parth, your slides were excellent. I mean, even not the content was very good, and even the maturity in your, the presentation, the making of the slides was also very, very neat, and the presentation was very good. And
thank you so much, ma'am.
Very appealing.
Ma'am, I really want to thank you, Umali madam and Jyoti Singhal madam, that ma'am, you all have given me the opportunity to present at a national level. Thank you so much, ma'am.
And it's good that we have a recording of this. So, and even the past recording seminars are going to be available on the Kidney Foundation for Children websites. I think it's going to be going into the bulletin will also carry the information very soon. So you can all access a few of the past seminars and guest lectures. And the next Tea Time Talks will be on 24th. And do connect, because Dr. Vaibhav Keskar will be presenting two interesting adolescents with steroid-resistant nephrotic syndrome. So, ma'am, should we end the session for today?
Just one thought, Jyoti. I see many names in the participants whom I'm not familiar with. So next time, maybe you could just give a little 5-10 minutes for people to introduce themselves, so everyone knows everyone.
Right, ma'am. Do you want to get people to introduce just now? We still have time, so today's people can introduce now if you like.
It's okay. I think next time start with maybe introduction so everybody knows who's where, and then we can proceed further.
Sure, ma'am.
Okay.
We'll do that, ma'am.
Yeah.
Okay.